Okay, welcome. This is our second week of the 3 weeks of the Grand Rounds. This is our third presentation. Esther Wawuru will be will be presenting her case on Parkinson's disease. I also want to thank Dr. Cosmel, who's not here, but he was the originator of the thought of, when I say he's not with us, he's just not present today. So he was the one who had the first thought of doing grand rounds, kind of in the medical model. And this is our first year doing it. I think it's going quite well. We also appreciate the feedback from faculty, physical therapy faculty, their input, suggestions on modification, improvements in the process, and we'll be looking forward to that continuing. And especially Dr. Barbara Wagner, who helped co-teach and organize the course. There wasn't much teaching. It was more the students doing the teaching, but more the organization. So let's give it up for Barb Wagner. Okay, Esther, you're up.
Good afternoon, everyone. My presentation is on Parkinson's disease. And this is a case that I inherited from one of the students who was ahead of us, I think 1 year ahead of us. And the patient is Mr. Tuttle, who is 82 years old, and he's a retired male. He was a computer programmer until he was 65 years old. He was diagnosed with Parkinson's disease 5 years ago and is alert and oriented ×3, and came to us seeking outpatient physical therapy services due to Parkinson's disease-related symptoms. His past medical history: he has myocardial infarction, congestive heart failure, hypertension, and had a transient ischemic attack 4 years ago, which I'll explain ahead of time. In his recent medical history, he has Parkinson's disease and is currently on drug holiday, which I'll also explain ahead, and also has moderate to severe cervical spine arthritis, is suffering from lack of sleep, and has depression. Social history: he lives alone in an adult retirement community with 3 steps to enter. By that I mean that he has his own independent house, independent living, his own apartment, and he also has 2 sons who live in another state, and drives short distances to the pharmacy against medical advice, does not use any assistive devices to walk, has a very great sense of humor, and has a girlfriend who visits him frequently. That is very important. Its reason for physical therapy referral is because of lightheadedness and feeling of drunkenness, and also the pain with cervical spine arthritis, and he also had difficulty with balance activities. Now, what is Parkinson's disease? I think most of us have heard what Parkinson's disease, but I'm going to go through it a little bit. This is a degenerative disorder of the cervical central nervous system, which begins in the 5th or 6th decade and affects people mostly 75 years and older. And in that category, it affects 1 in 100 people. The estimated prevalence in the United States is 500,000 people, and is one of the leading causes of neurological disabilities in the US. Caucasians are affected more than African Americans, and Parkinson's disease has also been described as a neuropsychiatric disorder, which is because of the prevalence of many psychiatric symptoms such as mood and anxiety disorders, psychosis, depression, and addictive problems. It is caused by an interaction of genetic and environmental factors such as pesticides, and also due to neuronal death, which is caused by oxygen-free radicals, which are byproducts of metabolism. And in the 1980s, some drug addicts decided to try to use MPTP, which is the methylphenyl tetrahydropyridine. They were trying to get themselves high using heroin, and instead of getting themselves addicted to that or using that, they injected themselves accidentally with this drug and caused themselves a problem with Parkinson's disease. Parkinson's disease is caused by degeneration of dopamine-producing cells in the substantia nigra, which results in decreased striatal dopamine and initiates the symptoms of Parkinson's disease. And this is the anatomy of the basal ganglia, which is the area of the brain that's responsible for dopamine production and involves the striatum, globus pallidus, subthalamic nucleus, and the substantia nigra. It is important to always do a differential diagnosis when you see a patient, because you might end up seeing symptoms that almost look similar. So it's always right to, you want to treat the right thing. And these are some of the differential diagnoses that you want to look at when you have a patient with Parkinson's disease. Some signs and symptoms of Parkinson's disease include bradykinesia, which is slowed movement, rigidity, shuffling gait. They'll also present with forward head, flexed posture, difficulty initiating gait, resting tremors, and they also speak in a soft voice, which is called microphonia. Mr. Tuttle is on drug holiday. This is a period when drugs are withdrawn so that the patient with advanced case of Parkinson's disease is allowed to recover from tolerance or toxicity. It could last from several days to several weeks. For Mr. Tuttle, he is on a 1-month drug holiday. A study conducted by Weiner et al. Was looking at the effects of drug holiday on 16 patients with Parkinson's disease, and they were evaluated daily before and during and also after the period of L-DOPA, which is a precursor for dopamine. And they found that 11 out of the 16 patients had enhanced motor responsiveness after the drug holiday. And they also found that most of the drug-induced effects, such as hallucination, decreased, as well as dyskinesias, and the on-off phenomena diminished. And on-off phenomenon is a pharmacological term that happens when patients, when taking the Parkinson's disease drug, which is Sinemet, when they are on the on stage, they tend to have a decrease in the symptoms, but when they get to the off stage, they tend to have the symptoms of Parkinson's disease, more like dyskinesias, the tremors increase. Impact of comorbidities. Mr. Tuttle has cervicospine arthritis, which is a degeneration of cartilage in the cervical vertebrae that causes pain in the neck and may radiate to the arms. This patient will present with muscle weakness, tenderness in the neck, stiffness, and loss of balance. He also has myocardial infarction, which is characterized by prolonged crushing, chest pain radiating to the throat, neck, and back. Congestive heart failure is characterized by sleep disturbance, psychological disturbances, decreased tolerance for exertion, among many other symptoms. And all this will have an effect on him in addition to Parkinson's disease. He also has hypertension, which symptoms include headache, drowsiness, among many others. Depression. For most patients with Parkinson's disease, depression is a major factor. They'll have social withdrawal just because they are not comfortable about their appearances, and they'll also have problems with falling asleep. He also had a TIA, which is a mini stroke that recovers within 24 hours. But patient who has multiple mini strokes may end up having a stroke and may end up having residual symptoms of a stroke, which could be weakness to one side of the face of the leg. And this may increase the risk for falls. And if you have any questions, please stop me. Some causes of balance impairment in patients with Parkinson's include loss of postural reflexes, visual spatial deficits, retropulsion. They also have problems studying or initiating gait. They have problems when they get to doorways where they freeze, fascinating gait, orthostatic hypertension, and true vertigo. Treatment of Parkinson's disease has three approaches, which include protective, restorative, and symptomatic. Protective involves use of new drugs to correct the imbalances in calcium homeostasis, while restorative is more invasive and it's the surgical procedure such as stellatomy and pallidotomy, which is for pallidotomy is removal of the part of globus pallidus, and for stellatomy is removal of part of the thalamus. Deep brain stimulation is also considered as a restorative procedure, and it involves stimulation of a part of the brain to reduce tremors and to help patients with Parkinson's with slowed movement so they can be able to walk in a more efficient and functional way. And I have a clip to show you. This is a patient who has Parkinson's disease, and this is before he had deep brain stimulation procedure done. As you can see, he has difficulty initiating gait. Look at his gait. He has problems starting the gait, but once he starts going, he goes. And that was bradykinesia that you saw him walking a little bit slowly. And now he's freezing, he's unable to start again. After deep brain stimulation, this is the same patient. You can see he has no problem with freezing at doorways. He was able to walk right out through the door, and his walking is more efficient. He can turn faster than he could before. Reaching is also better. His posture is not as flexed as before. Another treatment approach is the symptomatic treatment, and this involves using L-DOPA, and it is considered to be the most effective treatment for Parkinson's disease. However, there is a controversy of early versus late treatment. By this I mean the physicians are wondering, should they give the drug earlier when the patient has just started complaining of Parkinson's disease, or should they give it later on when the patients need it most? When they give it earlier, it will improve the quality of life with these patients when they're still younger. When they're older and the symptoms are more progressive, that is when they also need the drug most. However, they have found that the L-DOPA doesn't work as efficiently as it could in about 5 to 7 years. So it still remains a controversy whether to give it earlier or later on. There are ethical issues of using human tissues. Many people do not support the use of using human fetuses in the treatment of Parkinson's disease. These are some of the medications that Mr. Tuttle is using. Nitrodor is indicated for angina, and some of the side effects that you will see with this medication include dizziness, lightheadedness, and daily headaches. He's currently on drug holidays, so he's not using Cinemet. But if he were using Cinemet, these are some of the side effects that you would see that include headaches, dizziness, and weakness. Diovan, which is indicated for hypertension, has the side effects of dizziness, fatigue, and joint pain. Zocor is indicated for high cholesterol and prevention of myocardial infarction, and some of the side effects include headache and weakness. Lasix is indicated for congestive heart failure, and side effects include weakness and drowsiness, while tramadol is indicated for mild to moderate pain, which is used for cervical spine arthritis, and side effects include dizziness and weakness. Agrinox is indicated for TIA prevention, and side effects include headache, while meclizine is indicated for nausea, vomiting, dizziness, and vertigo, and side effects include drowsiness, confusion, and nervousness. Mr. Tuttle is also having problems with sleeping, so he's taking Lunesta, which is indicated for insomnia, and side effects for this medication include drowsiness, headache, and dizziness. Therefore, you can see some of the problems that he has, such as dizziness, could be all the result of some of the medications that he is taking. This slide is just showing some possible side effects of the medications that I looked from the previous slides, and I just wanted you to have an appreciation of them. A comparison of effects of medication to patient symptoms. The patient is complaining about impaired balance. This could be the result of dizziness, weakness, and fatigue. You can see at the bottom of the left-hand column, he also has dizziness, which is a patient symptom as well as an effect of medication. Some of the factors affecting gait in patients with Parkinson's disease. As normal part of aging, people have the increased time with double stance. They also have decreased arm swing during gait. So all this, when combined with the symptoms of Parkinson's disease, the patients also have difficulty ambulating, so with the immobility, disuse, bradykinesia, fascinating gait. All these are factors that are going to be limiting function with these patients, as well as musculoskeletal impairments such as weakness and cardiopulmonary impairments, leading to decreased aerobic capacity. Mr. Tuttle will have problems walking at home. These are some of the things that I anticipate with him. He'll have problems walking or ambulating at home and in the community because of freezing. He'll also have problems with transfers, moving from supine to sit. He'll also have problem turning around. As you saw in the video clip, patients with Parkinson's disease have problems turning around, and with functional activities that require performance of motor skills are also compromised. Multitasking with a patient with Parkinson's disease is a problem. If you ask this patient to carry a tray and at the same time walk, this will be very difficult. Role of other healthcare workers. It is for physical therapists to recognize, it is our duty to recognize some of the symptoms with patients that we see. If we see a patient with the on-off phenomenon, we can refer them back to the physician and tell them this is what is happening. Maybe the patient needs to have his dose adjusted for the Cinemed. Also, the RNs are responsible for administering medication, while occupational therapists work on ADL as well as upper extremity function. While Mr. Tuttle came to our office, he presented with a slight forward head and shoulder posture. He had decreased arm swing during gait, a masked face. It was difficult for him to just tell him to spontaneously smile, and he also had slurred speech. During our examination, we decided to look at the modified Hall-Pike disc maneuver, the Brent-Darrell, and functional positioning test. All these are tests for vertigo and to test for vestibular disorders, just because he complained of lightheadedness and drunkenness. We also assessed his cervical spine range of motion, functional axial rotation measure, which is a measure of the movement of the axial spine. With this test, the patient will be asked to cross their hands, their arms in front of their chest, and to turn around posteriorly. And you're going to see how much they can be able to move. the functional reach test. We also looked at the pain levels by asking him to rate in a scale of 0 to 10 how much pain he has, gait assessment, and strength measurements. Our objective measurements, he complained of pain of 5 out of 10. His strength for bilateral upper and lower extremities was 5 out of 5, and cervical left rotation was 26 degrees, and to the right was 45 degrees, so you can see to the left it was more limited. Functional axial rotation to the right was 138, while to the left was 150, and his tug and functional reach scores were very indicate high risk for falls because the tag 22 seconds to walk a 3-meter gait is very long, as well as reaching 6 inches is an indicator of high risk for falls. During our assessment, we concluded that he had significant limitation in the cervical spine range of motion, as you saw earlier. Poor posture attributed to changes related to Parkinson's disease include the flex posture. Assessment tests for vertigo were negative. He did not have nystagmus, so we ruled out vestibular problem. Also, the tag, as I mentioned earlier, 22 is a high risk for falls. Our plan was to see him twice a week for 8 weeks. Our short-term goals include to decrease pain from 5 on the cervical spine from 5 to 2, and to improve cervical spine range of motion by 10 degrees, and to improve balance by decreasing time on the tug test by 5 seconds. Long-term goals include to improve functional axial rotation of the cervical spine by 15 to 20 degrees on both sides, to demonstrate improved balance by decreasing time on the tug by 5 seconds or more, to improve gait by increasing heel strike, trunk rotation, and step length 70% of the time, and to demonstrate improved balance by increasing functional reach ability by 4 inches or more. The practice pattern I selected for this patient was 5E, impaired motor function and sensory integrity associated with progressive disorders of the central nervous system. Our interventions included soft tissue mobilization, where we used moist heat before we did manual stretching, range of motion exercises, as well as balance training, where we did activities such as limb stands and tandem gait, as well as ball toss in standing with emphasis on reach, physio ball exercises to emphasize good posture, and mat exercises that will encourage weight shifting, as well as being able to walk in a straight line. We also did activities including that involved trunk rotation, gait training, emphasizing on speed, step length, heel strike, and cadence, good upright posture, and gait training with auditory and visual cueing. Reassessment on August 3rd, 2007 showed that Mr. Tuttle had improved from 26 to 43 degrees in the left cervical spine rotation, while for the right it improved by 3 degrees, though it was still more than for the left. It was still better than what it was before. Functional axial rotation improved to 149 degrees, while for the left improved to 153, and the tug scores improved. They were significantly better. They were 13 seconds, and functional reach still indicated a risk for fall. The patient also reported decreased pain. He also had improved step length as well as speed. There were no reports of falls since initiation of physical therapy, and he did not complain of any lightheadedness. Mr. Tuttle was discharged on November 2007. He was given a home exercise program that involved walking without a device and therapeutic exercises using light calf weights, balance activities of some of the activities that we were doing at this at the clinic, including single limb stance and tandem stance. And at discharge, it was recommended that he goes to a neurologist for follow-up. And he was also advised to join support group of other people who had Parkinson's disease, as well as patient education, which is very, very important. This is this is an article that I looked at about external rhythmic cues. It evaluated influence of rhythmic cues on gait interference during functional activities, and also the relationship of clinical symptoms to gait interference. They found that auditory cues during dual tasks involving gait reduced interference of the task, and they also found that there were significant increases in step length. Another study that I looked at had an objective of reporting the results of a pilot control study of gait and step training in individuals with idiopathic Parkinson's disease who had poor balance or recent falls. Gait training involved walking on the treadmill at greater speed than overground walking, walking in 4 directions with a harness support for safety. Treadmill was turned on and off in either forward, backward, or sideways direction to mimic perturbations. They found that there was a reduction of falls with these patients, the gait speed increased, and there was greater overall improvement in cadence. And the patients also had improved stride length, speed and the speed of step test. In another study that I looked at, they were trying to find the efficacy of a rehab program to improve postural stability and walking to overcome freezing. The patients who performed weight shifting exercises in various positions where perturbations were applied with eyes open and one eye open conditions to enhance limits of stability. And they found that these patients improved in the freezing of gait, in the freezing of gait questionnaire and Parkinson's disease quality of life questionnaire, but not in the unified Parkinson's disease rating scale. Additional studies that I looked at found that interventions on home-based rehab program improved motor performance compared to patients who did not have regularly professionally designed exercise program. This means that we're supposed to, when we send our patients home, we need to come up with a good exercise program for them to go at home with. Also, multidisciplinary approach allows most patients with Parkinson's to maintain or improve motor function for up to 3 years after initiation of the program. I spoke with Dr. Hakim about what she thought about this patient, and she told me that it is important with Parkinson's disease to consider the HONE and YAR staging, because Parkinson's disease is a progressive disorder, so we need to keep following up. We need to know what stage they are in to be able to come up with the right interventions. And physical therapists should focus on secondary impairments, because these patients will have things like flexed posture and among many other types of symptoms. And physical therapy management should include instructions on compensatory motor strategies. We should teach them how to compensate if they cannot be able to perform the activities that they used to before. And it is important to include a home exercise program, regardless of the stage. And it's always very important to address fall risk, because these patients are very prone to fall. Why is this important to physical therapy? External temporal constraints provide a means of organizing and timing the timing and speed of movements that compensate for loss of internal cueing. Also, use of rhythmic auditory stimulation demonstrates an increase in gait velocity, cadence, which means it's important to use these cues. Visual cueing has the greatest effect on stride length, as well as decreased time spent in double stance, and this decreases the risk for falls. Cueing and feedback appear to have greater effect than non-cued or traditional activity. Training caregivers on appropriate use of verbal and visual cues, And we should always evaluate the home. If at all they have grab guards to prevent falls. And physical therapists should recognize that submaximal responses to exercise testing are affected by Parkinson's disease, with higher heart rate and increased oxygen consumption. Conclusion, we should have a specifically tailored rehabilitation program to modify the freezing of gait, as well as to improve the gait parameters and quality of life. And multidisciplinary approach, including home exercise program, health and wellness, education, as well as support groups are important for the overall improvement of these patients. Any questions?
Yes, Esther. You mentioned there are some medications that Mr. Turtle was taking that regulate calcium homeostasis. Can you just explain a little bit on how calcium would affect the disease progress?
Give me 1 second. With calcium, it helps. Calcium is good for bone density, so that will help with the patient to increase their bone density. So if a patient is not taking calcium, they'll be at risk of falls and they may even have fractures.
Oh, I just thought that for some reason you had it related to Parkinson's disease. This was just a secondary effect.
Okay. Do you know what medication that was? I cannot remember.
I think it was your second slide of medication. Oh no, I'm sorry, it wasn't the medications, it was the preventative treatments,
I'm sorry, the what?
the initial treatments
Okay.
before deep brain stimulation. There we go. Yeah, you said something causes.
Yeah, that's a good question, and I'm not very sure about the drugs and how this influences this, but maybe the drugs are taking that into consideration.
Okay. Thank you.
I have a question about those young punk kids who were doing the drugs.
Yes.
Okay. Were those Parkinson's syndrome transient, or was it permanent? Do you know?
No, I do not know about that. All I know is that I read that they actually, when they injected themselves with that drug, they ended up getting the Parkinson's disease.
See, kids, we learned something there. Also, I have a question about the deep brain stimulation.
Yes.
Are there side effects of that, and typically how long do the benefits last?
I am not sure how they last. I talked to one of the professors about how long this could last. I am not very sure. I don't know if it has been confirmed about how long these effects are.
Okay. And last question, PNF, specific PNF intervention, are there any techniques you did to decrease the general tone and rigidity with the patient?
We did not use any PNF patterns, but we actually worked a lot on stability or using physical exercises, and we tried not to use fast movements that would increase tone.
Thank you.
Any more questions? Yes.
I do have one more question. How long did you see the patient for his physical therapy treatment?
8 weeks.
8 weeks. And this was outpatient?
Yes, this is
Oh, okay.
outpatient.
Thank you.
All right, and I'd like to thank Dr. Leiniger, Dr. Wagner, and Dr. Hakim for all their assistance, as well as Nick and Zilkar during the research. They helped a lot. Thank you very much for everything.